I'm Dr. Lucy Hooper. I'm a GP, and as a doctor, I am passionate about health screening, about early detection and prevention of illness. And this podcast is all about your life, longevity insights for everyone, and how we can help you live a longer, happier, healthier life. And I am joined by Dr. Hugh.
Hello, Dr. Lucy. How are you today?
I'm great.
To introduce myself, I'm Dr. Hugh Coyne, and I am Dr. Lucy's husband. And we are also co-founders of Coyne Medical, which is a private practice in Fulham where we try to look after people's long-term health, try to do early prevention and detection of disease, and try and do that while looking after the whole family. What are we talking about today, Lucy?
So today we are talking about why we look further than 10 years ahead, specifically when we are talking with our patients about their risk of heart disease.
Mm-hmm.
So why 10 years is too short a time frame.
Okay. Who's looking only at 10 years as a time frame?
Well, pretty much everyone, to be honest. Not everyone, that's not fair. But a lot of doctors, clinics, big healthcare companies, organizations like the NHS, lots of people are still classifying people according to their risk of cardiovascular disease in the next 10 years. And that is a missed chance to really prevent cardiovascular disease. And remember, cardiovascular disease is still the number one cause of death in the UK. So not just disease, i.e., people that are unwell, that are suffering, that are not able to live their lives as they want to, but also actually people dying of that disease. It's a huge, huge problem. And the really tragic thing is 80% of those deaths are preventable.
Wow.
80%. It's a huge chunk that are preventable if we do the right thing. If we really help patients address these risk factors, and if we help them live a healthier life, then we can prevent an enormous amount of disease.
Yeah, that's a really impressive statistic. And it's really interesting because we know that most of the improvement in cardiovascular health and the improvement in preventing people from dying of strokes and heart attacks in the last 20 years has come from better preventative medicine, not from interventional cardiology. So not doing the fancy stuff like the stents in the cath lab where they put in the catheter into people's groin and they thread it through the blood vessels and then put in the stent. That's not where the lives are saved. It sounds exciting and very sexy.
It is exciting. Yeah. The fact that people can go in and they can open up those blockages and save someone's life and literally stop a heart attack in that instant, stop it happening. And you talk to patients and they will say, suddenly the cardiologist did this and they could just feel, oh my gosh, all that pain and pressure has gone. And, they feel like they're cured. They're not cured, but they're cured for that moment, from that really sudden event. But yeah, you're right. Our management of things like heart attacks has changed immensely, certainly even over our, 20 plus years practicing as doctors. How we deal with those problems has changed enormously. We used to give injections.
Has it been that long?
Yes, it's been that long. I mean, do you remember in the early years working as a doctor, there was we used to give injections to try and...
Door to needle time.
Yeah, exactly. Door to needle time. It was the time when someone has a heart attack, the time from them coming through the doors of the emergency department to getting that needle in and getting those clot-busting drugs into their system to stop the heart attack happening. And now that's old hat. That's all gone. But so yes, enormous progress in treatment. But you're right. If you were to analyze and look at the data, actually most of the improvement has come from other things, particularly smoking. So reductions in smoking have led to, worldwide, globally, reductions in cardiovascular deaths, and other medications like statins and things like that. But there is still a huge amount we can do, and it's still a massive problem. And it matters so much to take action on cardiovascular disease when you feel well. Most of us, especially us, as you get into your 40s and older, that
you don't look it.
Oh, thank you. That you still feel
You're supposed
young.
to say that I also don't look in my 40s.
You also don't look on your 40s, Hugh.
It doesn't count now. Come on now.
But it's so important that we deal with this stuff while we are still feeling young. And obviously, as I get older, my definition of young keeps shifting. One of my patients said to me recently, and I said, "Oh, you're still young. You're only in your 40s." And they said, "Oh, thanks. That's nice to be called young." And I said, "Well, don't worry, because I'm in my 40s as well. So as long as you stay my patient, I will forever say you're still young."
That's a great mechanism of patient retention.
Yeah, exactly. Yeah. We'll always be young. We'll always be too young.
For any doctors listening, we've also got tips, business tips.
Exactly. But it's very important to look at it when people still feel they are too young. And we'll talk a bit more about kind of when to think about it later on. But certainly, early action matters. We know when we look at people, say, that have died at a very young age from other causes. So maybe someone has died in an accident or something like that. Teenagers, people in their 20s. Even those really young, healthy people, you can still find evidence of cardiovascular disease starting, And certainly the people I see when we're talking about cardiovascular disease that are into their 20s, 30s, 40s, I say to them, you can't feel anything now, you feel well. But that heart attack that maybe happens when you're 60 playing tennis, that process of that blockage building up to causing a heart attack, that has started 10, 15, 20 years or more ahead of time. So if we want to actually prevent cardiovascular disease, we need to be acting early.
Yeah. I mean, one of the things that I think is astonishing, I still think it's astonishing, is that in asymptomatic patients, so in patients who don't have any symptoms, they don't have chest pain, the number or the proportion of people who present their first presentation of heart disease is with a heart attack. And in the UK, that's almost a third of people. Their presentation of heart disease is having a heart attack. I just think that's remarkable. And then the rest, they are presenting either with stable angina, so they're coming in with chest pain, or in heart failure. So it's already got so advanced that their heart isn't pumping efficiently.
Yeah, that organ is failing to do its job. Exactly. And, when we think about that, that heart attack happening as a first event, that's part of the problem, isn't it? So you have no warning. You are playing tennis, you're doing whatever, and all of a sudden you're experiencing a heart attack. And heart attacks also, happen at a young age. We often think about, like I said, people in their 40s, like me, think we're too young.
Yeah.
I don't need to worry about it yet. But actually 20% of heart attacks in the UK happen under 65.
Yeah. And that's
so that is people in their 40s, 50s, very early 60s, well before retirement age, when you're still, in theory, busy working in your prime, that they are having a heart attack, which unfortunately some of those will be fatal.
Yeah.
Well, will be their first sign that they have cardiovascular disease.
Yeah. Yeah. Which is really sobering, I think.
Yeah. Yeah. But, we shouldn't be too negative about it, because I always come back to with patients that fact that we can prevent 80% should mean that we actually are just really motivated to try and get as much of that 80% as possible.
Yeah. Yes, absolutely.
So we started off by talking about the problem with looking short term, looking at just the next 10 years for risk. So tell us a bit more, Hugh, about how we've traditionally looked at cardiovascular risk.
Well, before we look forward into looking at people's risk, I just want to look a little bit back to sort of how cardiovascular disease has been over the course of history. So lots of people think of cardiovascular disease as being purely a modern phenomenon, but actually Egyptian mummies have been found to have evidence of atherosclerosis. So that's the buildup of plaque in their arteries. And they study mummies using imaging techniques, so whole body CT scanning, near infrared spectroscopy, and they demonstrated calcification in the and also cholesterol-rich plaques in these mummies, in their coronary arteries, in their carotid arteries, in their necks. So there's this very famous study, the Horus study, which evaluated mummies from ancient Egypt and other pre-industrial populations. And they found that there was quite a lot of atherosclerosis in Egyptian mummies. And so it's not just a modern phenomenon, but interestingly, the lifestyle of mummies in Egypt would have been slightly different from most of the population in that they would have been much more affluent. There was also higher levels of obesity.
Well, yes. Well, they had all those slaves, didn't they, in Egypt?
They did. So the more affluent would have had people do everything for them.
Yeah.
While the poorer population would have been there slogging away and doing plenty of physical activity to prevent their cardiovascular disease.
I could do with a few slaves myself, especially to do a bit more
tidy up after the kids, you mean?
Tidying up after the kids, exactly.
Yeah,
exactly.
I mean, you think they're supposed to do that for us, aren't they? That's the point. Except they just leave a trail of destruction around the house.
Now, one thing before we talk, so it is really interesting to think that, cardiovascular disease is not a new problem. Yeah. I'm conscious that we used quite a few different bits of terminology in that thing. So when we talk about cardiovascular disease, and then you mentioned atherosclerosis, maybe you might want to just explain what you meant by that.
So atherosclerosis is the buildup of plaque in the coronary arteries and in other arteries.
Yeah. So blockages. So when we say plaque,
blockages,
what we mean.
Yeah.
So is that where the blood vessel, which is literally like a pipe, supplying blood to the heart muscle, that you get build up, which starts actually in the wall.
Yeah.
So inside the wall of that pipe, that you get build up that starts to enlarge and eventually will start to reduce the amount that can go through. Well,
I think so. The pipework analogy is often used, but I think it's really important to remember that this is a dynamic living structure, not an inert bit of metal pipework that's getting blocked with limescale.
Yeah.
And what actually happens is that the plaque that forms inside the artery wall causes a process of inflammation inside the wall of the artery, and then the plaque ruptures. And
so it builds up and it will get bigger typically, but a lot of plaques will then actually, as you say, rupture. So that means that surface opens up. And the problem with that is that when that happens, all the blood that's rushing past will then become a big clot.
Exactly. Yeah.
And when you then have a big clot of blood in that tube, in that pipe, you completely block the blood supply all of a sudden.
Yeah.
Because you've gone from maybe you just had some atherosclerosis, maybe you just had that plaque building up that may be restricted, maybe 20%, 30%, 40%. But actually, for a lot of people, they may not necessarily have any symptoms from that.
Yeah.
That degree of blockage, our body is able to cope with that and, get around it. But when that 20, 30, 40%, then when it bursts and then actually you get this big clot forming in the tube, in the blood vessel, then that goes from 30% to 100% in seconds.
Yeah.
And when that happens, you lose blood supply to whatever that blood vessel was supplying. So if it's one of the blood vessels around the heart called the coronary arteries, then the part of the heart loses its blood supply almost instantaneously. and we feel that, we experience that as people, we will feel that we are having a heart attack.
Yeah.
So we might have chest pain, which can be very intense.
Yeah.
But some people also just get pain that's a bit less intense. They get sweaty, they get nauseous, they feel short of breath.
Yes.
All these different.
And the sense of impending doom.
That would be the medical textbook. Yes,
Yeah.
this feeling. But people, some people really do have a sense, that
something bad's going on.
It's bad.
Yeah.
Exactly.
Yeah.
Exactly. So sorry to digress a little bit, but I just thought, I was conscious that we used quite a few terms there.
So cardiovascular disease, so that heart attacks, strokes, not a new thing, but actually it's evolved from being a relatively rare thing in the 19th century and at the beginning of the 20th century. But by the mid-20th century, coronary heart disease has become the most common cause of death. And it's driven by this increasing prevalence of that process we just discussed, atherosclerosis. And it's because of rising rates of cigarette smoking and dietary changes and reduction in physical activity. And
also that we're living longer.
And we're living like that, absolutely.
We're not dying in our 20s, 30s, maybe from, certainly, it's not as common to die in an industrial accident, say, a farming accident, or to get an appendicitis and that to be fatal.
Yes.
Because there's no surgeon there to cure it, or there's no antibiotic and those kind of things.
Yeah.
So we're living longer to allow ourselves to get some of these other conditions.
Absolutely. So going back to your original question that you asked me before my diversion to Egyptian mummies and the 19th and 20th centuries. So in the UK, we have this organization called the National Institute for Health and Care Excellence, NICE. And they give recommendations to doctors on how to manage certain conditions. And they have recommendations about how doctors should estimate people's risk of heart disease. And how doctors do this is through risk calculators. And the focus of NICE in the UK is exclusively on 10-year risk estimation. And as a result, long-term risk can be underestimated in younger adults, in women and certain ethnic minorities as well, and also people with a strong family history. And the reason for this is that these 10-year risk calculators are really heavily weighted for age. And it's a thing that we often play around with, and we show patients this with the 10-year risk calculators, is that if you add 10 years to the age, the risk doesn't go up slightly, it goes up exponentially. And the analogy that I often give people is using only a 10-year risk calculator is a little bit like going on a really long journey. So say you're driving from London to Newcastle, but instead of putting in the whole journey in your sat-nav, is deciding we're only going to put in the first 10 miles and see where that takes us. And then we're going to do another 10 miles north and see where that takes us. And that's not going to give us the best, most efficient journey. And it's the same with these 10-year cardiovascular risks. So
You're so gentle, Hugh. I'm much more blunt typically with patients. I often say to people that 10-year risk is fine if you only want to live 10 years.
Yeah, that is.
If you would like to live longer, we should be looking longer term.
Yeah. And the other thing is that people can have very high blood pressure, very high cholesterol, but because they are young, their 10-year risk will look relatively low in these risk calculators. So the under-recognition of risk over the longer term beyond 10 years can mean there is missed opportunities for early prevention strategies, whether it is dietary strategies, exercise strategies, improving sleep, stopping smoking, trying certain medications. It's a really big issue, I think. And there's also the issue that it can really underestimate risk in women as well, in particular, and particularly in people, as I said, who have a very strong family history of cardiovascular disease.
Yeah, exactly, because it just doesn't take account of that, does it? And like you said, just playing around with them is often a really useful tool to see, because it's incredibly hard to be in those high risk categories, like you say, to meet those UK government criteria to recommend action. It's very hard to meet them in your 40s, say, or your 50s.
And this is one of the areas where I think UK healthcare is a little bit behind, because the European Society of Cardiology specifically recommends lifetime risk models. The American guidelines also recommend the use of lifetime risk models. So this is from the American College of Cardiology. So it's important to recognize that the rest of the world is way ahead with this.
Yeah, exactly. Yes, it's another area where sadly in the UK we're not leading science. On
the other group where I think it's really important to think about lifetime risk is those groups who are at borderline risk for their 10-year risk, and where a decision maybe to start treatment is a little bit in the balance. And in those cases, doing a life risk estimation can clarify for the doctor and the patient the long-term benefit of doing a treatment like a statin or a blood pressure medication or stopping smoking. And one of the interesting things when we play around with those lifetime models is how big a difference the interventions make over a lifetime compared to over a 10-year risk. And I think those illustrations of how much of a difference those interventions make over a lifetime have a much more profound impact for the patient.
Yeah. So explain a bit more. Maybe it would be useful just to define when we say lifetime risk, what do we mean versus 10-year risk?
Yeah, that's a really good question. It depends a little bit on the calculator that you use. So some calculators, for example, are up to 99 years of age, and some go up to 75 years of age, thinking more of average lifespans. So it depends a little bit on the calculator, but essentially it's a really valuable tool, particularly when people are young, because, for someone who is 35 that has, say, very high blood pressure or really poor cholesterol, if you just input the number over the next 10 years, their risk is going to be really low. But over a lifetime, that blood pressure has or high cholesterol has a cumulative damage on the wall of the artery that puts those people at higher risk. And that's why those long-term risk calculators are so valuable.
Yeah, you're right. There's different ones for looking at lifetime risk. So you want to know which one you're having. Otherwise, it's a bit like comparing apples and oranges. But generally, we're looking at lifetime risk, say up to 75 or 80 years of age. And I would normally say for most patients, thinking about what's my chance of, say, having a heart attack or stroke before 75 is a pretty good marker to be aiming for. Like, that should be an achievable thing for most people. That by the time we get to 75 nowadays, most of us would like to think we would be well, hopefully retiring, enjoying that retirement somewhere sunny, and, certainly not dealing with really serious health issues like a heart attack or a stroke.
Yeah.
You know,
And that idea of enjoying retirement, that's something I often bring up when we use these calculators. And when I'm showing patients the difference between these 10 years and these lifetime ones is, I might be projecting forward to people and saying, well, okay, in 10 years, you want to be retired. Look at how much your risk goes up in 10, if I just add 10 years to your age. And
if we do nothing, if we do nothing, let nature be natural.
Exactly.
Let nature take its course.
And suddenly the risk goes from, say 4% to 20%. And we've missed a whole opportunity to have been mitigating those risk factors over a really long time.
There's a new biomarker people have started talking about, and there have been quite a few studies published in the last few years on lifetime LDL cholesterol exposure. And I think this is really interesting.
Yeah.
And I can see how we are going to be using this, I think, going forward.
Yeah.
It's going to take a little bit of tweaking to work out exactly what's the best way of calculating it or estimating it. But so essentially it's looking at not just what your cholesterol is when you come and see me in the clinic at that point in time, but actually trying to track back with patients and see, well, what has their LDL cholesterol levels been over that person's lifetime?
Yeah.
And that is super important because you could have two patients with exactly the same blood results, but maybe one person, actually their LDL cholesterol has been high since they were a teen, preteen. And, they've just, trundled along with that risk. And you could have another person, and occasionally I see this, someone who actually, I can look back and see historically, actually their LDL cholesterol was usually pretty good, but maybe something's happened in the last year and, the wheels have fallen off with nutrition and exercise and alcohol and all these things. And suddenly it's climbed up. And looking at it that way is really important because it makes such a difference to how you can talk to that person about their risk, because the person actually has got very short-term elevation in LDL cholesterol. You're going to be much more inclined to say, okay, well, let's see if we can get back, because you were just, your levels were great just a year or two ago, and they'd been great for years before that. So let's see how can we unravel here and get back, versus someone where their lifetime exposure has been high throughout.
Yeah.
You can think now we've talked about the biology and how those plaques slowly build up in blood vessels. You can think, well, gosh, they've got a lot of years of build up probably already gone on.
Yeah.
We should be a bit more proactive with that person and not just keep letting the years slip away.
Yeah, because it's all about the exposure of the lining of the artery, the endothelium, to LDL over time. That is the major factor.
Yeah,
absolutely. And what about this idea, the plaque threshold?
So that's like I just mentioned, we're talking about lifetime LDL exposure, and there's, different ways of measuring that. And there's people have already come up with different cutoffs for, what might be a harmful amount of LDL cholesterol to be exposed to over so many years. But yes, and then there's this theory of what we call a plaque threshold. So what that means is that you could have a person with the same LDL cholesterol exposure over their lifetime, but that one person that might have led to these build-up and plaques and disease occurring, and another person, they may not have any plaques yet. And that plaque threshold, so how that LDL cholesterol translates into plaque, will probably be very different from individual to individual. And that's because it will rely on other stuff that we know about, so other risk factors.
Yeah.
So things like, one of my favorite topics, lipoprotein little a.
Yeah.
But other things, like blood pressure,
smoking,
nutrition factors. So lots and lots of other factors. So so I can see that we're going to keep on refining these markers and these ways of looking at.
And I think one of the things actually that all of those risk scores do quite well is that they show that risk factors in cardiovascular disease, they're not just additive, they're multiplicative. So
Yes.
they amplify each other. They
Exactly.
compound each other.
Yeah, we know that if you have, say, 2 risk factors instead of 1, so say you have high LDL cholesterol and high blood pressure, it doesn't double your risk. It more than doubles your risk.
Yeah.
You get this, you get this multiplying effect with more and more risk factors.
Yeah.
And going back to lifetime LDL cholesterol exposure, there was a really exciting new treatments that are in trial at the moment where they are actually giving people drugs which edit their genes. And it's a little bit sort of, I don't know, I'm trying to think of a movie where they did this. I'm sure there must be one. It's a bit sort of Jurassic Park-esque, isn't it?
I don't know.
Wasn't there a bit of gene editing in the beginning of Jurassic Park? A little
Maybe
bit of
that's
something.
stretching my memory quite a bit.
It's stretching
when
mine
did
too.
Jurassic Park
anyway,
come out? Were we teenagers?
We were young. But anyway, so there's these new drugs and they edit a gene which is really important for how the body clears harmful LDL cholesterol from the bloodstream.
This is PCSK9.
The PCSK9 gene. And they have found a way of editing this gene so that it allows your body to be much more efficient and much better at clearing LDL cholesterol from the bloodstream.
Yeah.
And in the early publications of this, they have seen an average of up to 59% reduction in LDL cholesterol from the bloodstream of these people.
Extraordinary.
It is extraordinary. And it's extraordinary because that potentially could be a lifelong effect. So there were these headlines when they were publishing, the sort of one and done cholesterol shot, was sort of the American headlines. And but it is potentially really game changing that we could potentially look at lowering someone's cholesterol at a really young age and that impact lasting them for a long, long time to come.
Amazing. Don't tell me because I already know, hopefully. But maybe explain a little bit about how we use lifetime risk in the clinic at Coyne Medical.
So how I think we should be using lifetime risk and how we do tend to use it is about us having a better conversation with the person about their health. Because again, it's about empowering people with knowledge to make the best choices for them, because identifying early on these risk factors, this risk that they've got a high lifetime risk of cardiovascular disease, identifying that early on means that we can actually change that. We can change the course. When you're far away from your destination, you've probably got some different routes and you can change the course. When you're right there, at the edge of the cliff, there's not many, you don't have many options ahead of you. But so the further back that we can impact things, the better. And it's really about changing that conversation to really prevention. Which, we're both passionate about, but about how can we actually prevent things and having that, much more ambitious goal of not just, are you about to have a heart attack tomorrow, but actually, can we do something now? And actually, we're going to prevent something 10, 20, 30 years down the line. That's going to mean you enjoy your retirement, that you are at your grandchildren's wedding, that the relating that back to, like you say, to like where do they want to be, how do they want to be living their lives. And
what calculators do you use?
So I probably most commonly we use 2 calculators. So the first being non-HDL risk tool.
Love that one.
Which came out a few years ago, which was one of the first ones looking at lifetime risk, which again, it's nice because it uses your cholesterol measurements that people will get in a regular blood test alongside things like blood pressure measurements, your height, your weight, if you have a family history, smoking, if you're diabetic or not, uses these things and it gives you a lifetime risk of cardiovascular disease. And the excellent thing is that, again, like you say, you can then also like game out a little bit with the person. So it allows you to put in, so say we would then doing something to lower LDL cholesterol or
Yeah.
non-HDL cholesterol, you can say, well, if we lower it by 30%, what impact does it have?
Yeah.
And you can play about with different options for that.
I think that's a really powerful tool, isn't it, to show patients if we do a 40% LDL or non-HDL reduction, how much does it change things? And then obviously you can take out smoking if the patient smokes as well. And
exactly. So it's really
cool.
like allowing people, to game out, well, okay, if I do these different things, what does that look like, down the line? And then the other one is LPA, clinical guidance, which is about incorporating lipoprotein little a levels and how they impact cardiovascular risk and incorporating those into lifetime risk of cardiovascular disease. And that's super, super important, and primarily for people with elevated lipoprotein little a levels, because it allows us, again, to really personalize that risk estimate for the person using their lipid measurements and lipoprotein little a level. And again, it allows us to play around with, well, if you reduce your blood pressure a little bit, what impact does that have? If we reduce LDL cholesterol, what impact does that have over the next 10, 20, 30 years?
Yeah. Yeah, I think they're really powerful and really, really useful. And because of that, they actually change care they're much more likely to change care than the 10-year risk score.
Yeah. And when we talk about changing care and taking control and helping patients take control, we're not just talking about statin medication, are we? We're not just talking about drugs.
No, absolutely. And that's the thing. It is not just about starting someone on a statin. It's thinking about all the contributory risk factors to cardiovascular disease. So it's thinking about how can we mitigate stress, and particularly work-related stress? How can we help improve sleep? Because we know that is a compounding risk factor for cardiovascular disease. Can we help the patient to stop smoking? Massive risk factor for cardiovascular disease, as we touched on. Can we help them reduce alcohol consumption? Again, another risk factor, particularly with heavy alcohol consumption. And can we optimize their diet towards a more Mediterranean diet with lots of oily fish and leafy green vegetables and nuts and seeds? Can we get them doing more physical activity, which, as you know, I think is the biggest lever we have to pull to really reduce risk of cardiovascular disease? And that comes from a whole heap of great studies on hunter-gatherer populations that are still around today. So the Hadza and Shamane, who have very, very low levels of cardiovascular disease, but do a ton of physical activity.
That doesn't mean I have to go around trying to catch my own dinner.
Well,
I can still go to the supermarket.
You could, but you gotta run there for about 3 hours.
Yeah. Well, I do love running, so that's a possibility.
So,
but I'm not sure West London is very conducive
to hunter-gatherer style of life.
Yeah. I mean, it can feel like a jungle. Don't get me wrong.
Yeah. So I was just looking for another excuse to go running with my shirt off.
Yeah. Of course. But exactly, I think the point is that, yes, it's like how we use this kind of information, use this looking at lifetime risk is about empowering. It's not just about...
Not about fear. Yeah.
Yeah, and it's not just about drugs or medication. Or I think one reply I get quite often from patients is people saying, oh, do I have to start a statin? Or if I start a statin to lower my cholesterol, do I have to take it for the rest of my life? Or do I have to take it for years? And I will say, you don't have to do anything. This is a process, is about giving you information and giving you choices, that you can choose to do nothing. But for a lot of people, that's not a wise choice. And you don't have to choose a statin, but it's just one of the tools that we have to improve things. So if you can improve stuff in other ways, brilliant. But it's for some people, unfortunately, and a lot of that is genetic. For some people, they can do absolutely everything perfectly, you know, be living a sort of, you know, they can look like Chris Hemsworth and, you know, have the diet of, I don't know, Elle Macpherson. You know, they can be, you know, they can be really perfect in so many ways and still have an incredibly high cholesterol level.
Yeah, you can be doing everything right, but cholesterol can be really unhelpful, or a lipid profile can be really unhelpful because of genetic factors, for example.
And then you just have to decide, okay, well, if I've exhausted all my other tools, then maybe, you know, we are fortunate to be living in a time where medication can help us. You know, I feel like we should do a whole thing on statins more in depth, but
definitely.
They're one of the most common ways.
Yeah, because there's a lot of fear around statins and a lot of misinformation in the misinformation age. What age do you think people should start looking at this?
I mean, you are really never too young, you know, and actually in the UK especially, and actually in most countries, we're really poor at identifying actually very young people and children with high cholesterol levels. And that's because there's no routine screening. And there have actually been studies looking at that and looking at, should we be checking, you know, in some places in the US, for instance, they would be doing a cholesterol level at children, say at 8, 9 years of age, because that's a very good point at seeing what's genetically what their cholesterol is like. But we're not good at identifying those young people, and that's a shame, because that, again, some of those will have very high cholesterol levels and miss out on prevention. But you know, those are people with kind of very particular things. But even, you know, people without very high cholesterol levels, you know, everyone really should be knowing. You know, even if you are in your teens, your 20s, and you've got an elevated cholesterol level, you know, for a lot of people, that does often reflect the choices they make, their lifestyle choices. And we know that actually what we call early life exposure, so people with high LDL cholesterols in their teens, in their 20s, is worse than later on.
So wrapping up then, I think the big message for people is all about the missed prevention opportunities that come from only using these 10-year risk scores, which are really ubiquitous in medicine, particularly in the UK, but not only in the UK, and how someone that is of a similar age to us in their...
A young 40-something.
Young 40-something, who has, you know, middling stroke high LDL, non-HDL, and who has a family history of cardiovascular disease, might actually score low on their 10-year risk score, but be high on the lifetime risk scores. And that women particularly often get underdiagnosed because of the age-weightedness of these tools, and that early intervention is so important. We're missing opportunities in medicine to make small changes now that can compound over time to massively reduce risk. And we've got all these new tools, these new medications, this new knowledge that helps this lifetime approach. And I think, you know, we always say, you know, is that, you know, don't wait for the disease to happen before doing something about it.
Exactly. And I think there was a paper that said, start early, stay low. And I think that sums it up. You know, it is important to start early if we really want to prevent cardiovascular disease, and to, you know, keep risk factors as low as possible for as long as possible, and that we can do it. Like you say, you know, 80% is preventable. We can do it. And looking at lifetime risk is a massively helpful tool to help us help us do that and help us work with people to really choose what kind of life they want to have.
Amazing. Thanks, Lucy.
Thank you, Hugh. That was great.
Yeah. Speak soon.